Hi, good evening. I'm Dr. Philip Macmillan. Thank you for joining me. And today I have another one of those clinical discussions with Dr. Shankara Chetty, where we'll be looking at various strategies to deal with some of the strange things that happen around superbugs in COVID 19. So we'll be looking at a couple of papers and then just having a clinical discussion about what we think is going on. Before I start, what I will say is just a quick reminder about a few things. Remember to join us with regards to our Vision Med newsletter. The link is in the description below. You will get access to our nitric oxide ebook, and we will hope that we bring you very valuable information in the near future with that. Additionally, coming up next week is navigating the COVID storm, spike triggered autoimmune response mechanism, looking at therapeutic options. So if you want to join us, please click on the link below and we would be happy to have you. So without further ado, let me add Dr. Shetty to the stage. And how are you, Shankara?
I'm fine, Philip. How are you doing? I hope everyone's
Excellent.
good in the audience.
Excellent, excellent. So, for those who don't know Dr. Shetty, he is one of the COVID experts who had zero deaths in terms of his innovative strategies for managing COVID 19. And I'll tell you this, I think that Dr. Shetty is probably one of the best clinical analytical minds I have come across. So, for me, it's always a pleasure talking to him. And today we're going to continue with that question about antibiotics in terms of COVID 19. Um, what what information do you have about this work that was done by Carlo Brogna and Joachim and Valentina and so on?
Philip, they've been my colleagues for a long while. We've collaborated through the pandemic. A lot of them contacted me, Joshim, Valentina, when they saw my work and understanding the immunologic implications of the illness itself. And that's where we were early on in the pandemic, understanding this is a dysregulation of immunity and how to actually treat that. But we got to a point where we were treating long COVID patients very successfully. But what we found was there was a subset of patients that when we got them into remission, when we stopped treating, the symptoms recurred. And so we wanted to look at that set of patients to figure out why are these symptoms recurring. And the commonality was that all these patients had gut symptoms. The common thing was all the patients that went into remission and then relapsed had gut symptoms. And then I brought it to the attention of the group that my initial article in 2020 that described the pathophysiology of COVID, the treatment, that kind of thing, mentioned in a one liner, just to stimulate some interest in that direction, that the Chinese early on had found a positive PCR rectal swab. And that could indicate a fecal-oral route of spread of this virus. Because we know that RNA viruses have the ability to infect bacteria and persist. And so I thought, well, if we got a fecal-oral route of spread, and remember this was an article written in July 2020. If we're dealing with the fecal-oral route of spread, then you could pick up this virus from fomites in an empty public toilet, and a mask would not be of any benefit to you. And so, ignoring that one method of transmission of the virus made the entire response to the pandemic illogical. There's no point looking only left when you cross the road. It might halve your risk of being run over, but it's only when you run over that you realize looking both ways is actually the solution. So
That's
I
a
think that's
very
the pandemic.
important point there. Now, I don't know if we've actually found clear evidence of fecal oral transmission. What we know is that the virus is clearly found in wastewater samples, in stool samples for up to, I think the longest was 289. No, I think it went over a year. It was a very long time that there was the production of these ongoing RNA, which could only be made by bacteria. And just before we go any further, I wanted to just take people back to the original study done by Carlo Brogna in Italy. And he was the first, I think, to highlight this. And
Yes.
this was increase of SARS-CoV-2 RNA load in fecal samples. And they were finding this. And what was standout in this research was, one, they found this was just showing the increase in RNA in the sample A, the people who were infected. No, well, actually, this is sample A, it's just blue. And when you put the supernatant from sample A into sample B, which didn't have infection, you can see here the viral RNA increasing significantly up to 30 days. And then what I consider the two most important things, they found four antibiotics: metronidazole, vancomycin, amoxicillin, and azithromycin, completely removed the viral RNA pre and post antibiotic compared to all these other ones. And then the final piece of the puzzle is that when you look at this here, I'll just zoom this in. When you look at this here, this is showing you the different genuses of antibiotics. At the top here is Clostridium, and here are the colors day 0, day 30. So dark blue is day 30. And you can see here Clostridium day 0 here, and by day actually 14, it's already at maximum amount and way beyond every other bacterial genus. And what you find is that completely wipes out bifidobacteria, decreases staph, decreases lactobacillus, and completely wipes out another one, rhodococcus. And even bacteroides is significantly decreased by day 30. So this is some serious stuff that is happening with regards to the infection. And this was seen from 2021. I don't think enough attention was given to that bit of research. Any thoughts about why?
I think Philip, well, a lot of the research that we've been doing has not been given enough attention, yet it's pertinent to improving the patient's quality of life. So I think we've got distracted by the virus and the vaccine, and we never really looked at how the virus itself is causing the pathology we saw. We saw a lot of neurologic symptoms that viruses don't usually exhibit. We saw a wide range of clinical presentations that couldn't be explained. And as a good scientist, you go look for the explanations. And I think we missed the boat in not looking at those simple positive rectal swabs and trying to understand why they persisted. And of course, Carlo also found, besides disrupting the gut microbiome and using the bacteria to replicate, he did find a whole lot of toxin like peptides. Now, if you look at those toxin like peptides being produced in your gut, any toxin that you drink goes through hydrochloric acid in your tummy, all the different acids and digestions. And so by the time it gets to your colon for absorption, it's no more toxic. So if you drink something like snake venom, it's not going to kill you. But if you inject it directly into your colon, then your colon is for absorption and it will be absorbed unchanged because it hasn't been exposed to the entire intestine. So it makes the gut microbiome an ideal target for toxin production because it will be absorbed easily and
Yeah.
unchanged. And that toxin production, Philip, besides having a toxicity all of its own, the toxin production, any toxin, is responded to in the same way as a cytokine storm. If we look at my understanding of the hypersensitivity, there were two things that would cause such a sudden dysregulation. It's hypersensitivity and exposure to a toxin. Now we have both. We have the hypersensitivity that gets triggered by the virus, but we also have a toxin production, which in its own has the toxicity, but can also trigger a cytokine response in a
Yeah.
system far away because
No,
it's being.
what's interesting is that when they looked at their study, because what they had to do was a retrospective study, I think it was about 200 um, patients that they looked at from 2020 all the way to 2022, who they had given antibiotics to. And I just captured here in this when they looked at the duration of disease here. So blue represents antibiotic treatment after 3 days, and red represents antibiotic treatment within 3 days. And you can see this very significant drop off by the 10-day mark. Most of the patients were better. It took up to 4 times as long for some other patients, a significant tail off with regards to symptoms. And I think they actually found as well that there was a reduction in the possibility of long COVID symptoms by using antibiotics early. But let's just be clear, we can't, antibiotics are a double edged sword.
Yep.
You have to be so careful with them because overuse increases the risk of superbugs.
Yep.
How did you look at it from your clinical experience when you started to see patients early on in the pandemic? What was your thought and approach to antibiotics?
Philip, I think as a general overview of the use of antibiotics, and I get these questions from my patients quite often. A patient will tell me, "Look, every time I bring my kid in with a infection, use the same antibiotic." Now, that's one thing doctors need to learn, that if you use an antibiotic and it works, then why shouldn't you be using it again? There isn't a trend. So when a rep comes and sells you a new antibiotic, it's not the newest thing on the block and you should use it. So the way I see it, I know that you have a microbiome that needs to be protected. If I influence it with the same antibiotic over and over again, I'm more likely to kill the new pathogen on the block, but develop antibiotic resistance by the good bacteria in your body. And so, as I use that antibiotic over and over, it has less detrimental effect to the good bugs in your body because they develop resistance to it. But the new kid that's causing the problem doesn't have that resistance. So it's this abuse of antibiotics is not in the overuse of the same antibiotic. It's in the diversity that you use that will kill a diversity of bugs indiscriminately. And so I usually look at antibiotics as using the same one if it worked with you and keeping it the same till I find there's resistance to it. Then there's a need to change to a new one. Now, from the perspective of COVID itself, the antibiotics that I used were only in patients, azithromycin being the choice, was only used in patients where there was clear indication of a bacterial infection, where they had purulent mucoid discharge, either coughing up yellow phlegm or yellow mucus from the nose that shows bacterial infection. I would put them on azithromycin. And promptly, you'd get clearing of that purulent discharge to a clear discharge. But I also, in those patients who didn't have that, prophylactically used doxycycline. Now, the reason for my choice of doxycycline is that although it's an antibiotic and a well known long term used antibiotic, safe, the effectiveness I expected to be in its ability to restrict protein synthesis. It inhibits protein synthesis at the ribosomal subunit of your cell. And if it inhibits protein synthesis, then it can inhibit technically viral replication because it needs to produce proteins to make a new virion. And so it can slow viral replication. And secondly, from the perspective of the toxins, which I didn't know at the time, it can decrease toxicity because both require protein production. And by slowing protein production or stopping protein production at the ribosomal subunit, it seemed an ideal drug to address viral replication. So prophylactically, every patient got doxycycline. Those with a mucopurulent discharge, it was changed to azithromycin. So I was lucky enough to start my patients early on, but from a different perspective, not treating a bacteria, but trying to inhibit a virus with another effect or beneficial effect of an antibiotic. So I wasn't using doxycycline for its antibody properties. I was using it for its ability to inhibit protein synthesis and so slow
Yeah,
viral replication.
one of the problems, I guess, is so when people are listening to this, you have to realize that it's unlikely that if you tell your doctor about this, unless they actually know this and there is a clear protocol for it, you're not going to get any antibiotics. So what we are looking at here is if we had the reach and the power to be able to develop these protocols and to try and give some guidance, what would that guidance be, and why? What would be the scientific rationale for doing it?
Yeah,
So when I think about it, what we know is that after an infection, if this person had a serum viremia, that means where they felt relatively unwell, virus gets in the bloodstream, the first port of call is the gut intestine. It then will get into the colon. It will then potentially use its bacteriophage properties to infect, especially Clostridium difficile. The Clostridium difficile then, for unknown reasons, starts to produce within a week to 2 weeks, produce lots of toxins, extra ones, that kill off the competition. And important to note that Clostridium difficile, this one that causes us so much problems in hospitals, superbug, is normally kept in check by the same bacteria that have been destroyed, the bifidobacterium. And so now suddenly it destroys these bacteria, it can have license to overgrow. So I am thinking that we have to anticipate that a significant proportion of people who had exposure to the virus, recurrent infections especially, will probably have an overgrowth of Clostridium difficile with extra toxin production and a deficiency of bifidobacterium and low numbers of lactobacilli. Okay. Now, what, firstly, should we actually be testing this to prove it, or do we just accept it?
Look, Philip, I think that's a question that's based on resource. Uh, yes, we should be testing all patients that have long-term symptoms or gut issues for an overgrowth of Clostridium, and if there's a deficit of bifidobacteria. And we should look at toxin production as well. Is there toxicity to these two samples? But then, does the resources we have allow us to actually do that with every patient? So, I would, from my perspective, when I treat a patient with long COVID, uh, if they have symptoms, gut symptoms that are persistent, clinically, if they show signs of toxicity, neurologic symptoms, brain fog, certain other symptoms that draw my attention to likely toxicity, then I can assume that the gut is infected because those toxins are coming from nowhere else. So I include in my long COVID treatment protocol a, a clear, well defined methodology to addressing the bacteria with the appropriate antibiotics, then immediately following the antibiotic with a purge to get rid of bacteria in the gut, and then providing them with the broadest probiotic I can get my hands on to give nature a chance to reset the balance. But
Can
if
I?
you cannot remove the virus, then it's going to reinfect the bacteria you keep putting in.
So here's a question that I've wondered about, because I agree with the first two bits, which is that one, actually, let me just think. If I could choose the timing, I would first clear the gut, so purge the gut completely, like they're going for a colonoscopy, then use the antibiotics, if you're going to use it, to clear the Clostridium, along with giving them something to reduce the toxins, something like charcoal, something
Yes.
that will bind the toxins. And then after that, then add the probiotics, which would be high in bifidobacteria, and hope that they then hold their ground and suppress, because you can't get rid of the Clostridium.
Yeah, yeah, yeah. You just have to reestablish the balance. To reestablish the balance, you got to take away the factors that are causing the imbalance, which is the bacteriophage activity, and that causes the viral load to go up and persist, and of course addressing the toxicity. So, like you said, activated charcoal to remove the toxins that are there. But remember, activated charcoal will remove the toxins, but if you got bacteria that are still producing them, it'll only work for as long as you give it. So you got to address the bugs that are actually causing the problem. So yes, uh, clearing the gut, cleansing the gut of the bacteria. Yes, you decrease the number of bugs you have, but you still need that antibiotic to actually kill the bugs that are the hosts that are producing the toxicity before you can actually introduce anything to actually regrow it and balance it. Got to remove the imbalance or the factors
This is
causing
not
it.
this is not a simple procedure. This is one of the things I've realized. It's not straightforward to fix. And this is taken into consideration because a cohort of these people, if they already had gut issues before this occurred, they already probably had changes to their microbiome. that
Yeah,
maybe they had an overgrowth of something else. And so they are not starting from point zero.
yeah.
It's very difficult to do blind.
If you look at the study, Philip, the 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 higher death rate amongst those patients with comorbidities was actually negated by the early start of antibiotics. If you looked at the both groups, so yes, starting if you have a comorbidity, you had an increased risk of long illness or severe illness. But if you got antibiotic treatment early, then it seemed to negate the effect of the comorbidity that was influencing the illness to a lesser extent in those that got the antibiotic. So we got to look at, yeah, the comorbidities play a part in every illness. In any illness, comorbidity is going to play a part in how it resolves because it will decrease your propensity to heal, whatever the comorbidity is. But the use of antibiotics to show a significant benefit in speed to recovery in a viral infection clearly shows that there's bacteriophage activity and that bacteria do play a significant part in the illness itself.
Mm.
Because when you remove them, you get a quicker speed to recovery.
So I've just got this is from the paper as well, where they show here this is liver, stomach, this large thing here, this is large intestine, and then they have small intestine here. And I think that they are indicating that there is not just overgrowth in the large intestine, but also in the small intestine. They are showing here this is a bacteria that gets infected, and this infected bacteria, like this one here, will start to produce all of these toxins like peptides, which damage the lining, making it easier for endotoxins to cross, get inside the bloodstream. Then some of these ones here will target other bacterias so that they have overgrowth of this, and it seems to be specifically the Clostridium difficile. And so you have this whole interaction happening in the gut that is largely overlooked by the medical community because based on just exposure to the virus, the whole world has been exposed. What we don't know is what percentage of the population has this going on. What would you think are the symptoms that suggest that they have this kind of dysbiosis present?
Look, I'd say, Philip, that depends on the patient specific. A lot of patients present with gut dysbiosis that was pre existing. They had irritability in their gut, all that kind of thing. And it seems those patients are more likely to have this kind of infection persist in their gut. So the good bacteria that are lacking in their pre existing dysbiosis make them more prone to developing the condition itself because of fewer bugs to kill. Clostridia could overgrow very quickly. But then, of course, as well, you got patients who developed COVID and developed gut symptoms with COVID. So there is that initial presentation of a gut pathology. Now, in those patients who developed gut dysbiosis or gut problems during COVID, you'll find a lot of patients present with a runny tummy for a day or two, those kind of symptoms. If that happens, there's two things to consider. Are we dealing with an allergic process in the gut? And that's where I saw the benefit of H2 blockers, cimetidine, ranitidine, famotidine seem to have a good benefit. But in those patients also, those would be the cohort that you'd consider. Do they have this intestinal viremia or the virus production that's causing toxicity, that's leading to toxicity? Remember, when you absorb a toxin, the the organ of target might be far away from the gut. So the toxin that gets into your bloodstream might cause symptoms far distant from the gut itself. So neurologic symptoms, brain fog, all those kind of things might be related to gut toxicity. So just not asking the patient how they're doing with their gut and their diet and their eating is missing a big chunk of what might be causing the overall clinical picture that we see.
You know, the other thing that I was just thinking about is that there are two drugs that keep on getting mentioned. One of them is ivermectin, and the other one that seemed to have shown benefit, certainly in the long COVID cohort, was metformin. And it's likely that both of them seem to have some degree of benefit with regards to the growth of bifidobacterium. And just so people remember what we were looking at, this is the picture here. At the top, Clostridium here has overgrown by day 30. But when you go down here, bifidobacteria within 2 weeks is zero. It's completely gone. And this is a good bacteria. This is something that your gut needs to keep things in check. Bacteroides
Doctor,
is reduced and lactobacillus is decreased. So we have this situation where these specific bacteria are significantly down. Will metformin, how could you see something like metformin or ivermectin being used in that situation?
look, both have shown, Philip, that with long-term use, they increase the bifidobacteria species in your gut. So it's more to bring up the bifidobacteria that will counteract the overgrowth of the Clostridium itself. But those are measures that are very targeted at bifidobacteria species. So when I look at it, yes, you can use it as a supplement to try and increase the species of bacteria, bifidobacteria, after you've removed the offense with the appropriate antibiotics and the gut purge and the rest. When you put in the right probiotics, you can enhance the survival of the bifidobacteria species by concomitantly using either metformin or one of the others, that ivermectin, that increase these bifido species in the gut or keep them resilient to counteract the overgrowth of Clostridia there. But in any event, increasing the growth of bifidobacteria might not be sufficient to actually overcome the Clostridia that are there. You need an army, not just a soldier. And so we got to look broadly at how to counteract this. And remember, every person's gut microbiome is almost a unique signature. We all have differences in the gut microbiome with differences in the amount, proportions of different bacteria that are there. That is something that I think comes from our environment, our immunity, how we tolerate our environment. I've said from the beginning, our tolerance to our environment and the way we immunologically respond to our environment is what gives us our fitness to survive. And so,
Mhm.
different people from different environments have different microbiomes, both in their gut, on the surface of their skin, in their lungs, in their sinuses, that actually are protective. And so we are a ecosystem of microbacteria. We're not just human beings like medical science sees us. So when you get a bug that's targeting your microbiome, it seems to be outside the realm of medical science because they don't see that we're actually more microbiome than we are human being.
Yeah. So as we close out in this short clinical session, and don't worry, people, there'll be more of them. When people are watching this and they know that they can't take this information to their clinician who may not know about this, any simple advice that you would give to a person, say you're talking to a relative in the US and
Yeah.
they don't have access to the therapy, what would you say to them?
Look, just from the perspective of the dysbiosis in the gut, forget the treatment of COVID as a whole and long COVID and that kind of thing. Just from the advice I could give them for their gut itself, you're dealing with two things. You're dealing with the gut toxicity, so activated charcoal, just to absorb the toxin so that it doesn't get into your bloodstream or decrease that load. Then you want to change the flora in your gut so that you restore the balance that's there. Now, to restore the balance that's there, they're going to have to go to a doctor to get an antibiotic to try and kill the Clostridia that are there in the first place. So, I would say if you're trying to convince your doctor of the research that's done, then I'd say a good purge of the bacteria, like we do with colonoscopy, or even something like castor oil, which has been used for generations to clear the gut, followed by a probiotic. But the choice of probiotic is vitally important. Now, when I look at probiotics, the ones that we commonly using, Philip, are the ones that come from fermentation. So it's all the yogurts and the kefir and those kind of fermentative processes that are used to generate the probiotics that are commercially available. The problem is that I think for a long while now we are all lacking in soil-based bacteria. because that's another good source of good probiotics. So children that played in the soil were always the strongest. Now suddenly we're not allowed to play in the mud anymore, and we sanitize everything around us. So I think spore-based probiotics, which are probiotics gotten from the soil, are vitally important. In that they haven't been exposed to all these viruses and all that kind of thing. So they're not going to be a selected host, or unlikely to be a selected host. And of course, spore-based probiotics tend to have a wide diversity of bacteria in them. There's a company here in South Africa that extracts them from the ground itself, from the rhizosphere, where organic matter is naturally degrading. And that compound has many bacteria in it, 42 different species. So I think nature has, if you remove the offense, a way of balancing itself. So, yes, as allopathic physicians, we remove the offense, but we've never been trained in how to restore nature's balance. And that's where the problem lies. In trying to restore the balance, nature knows how to take care of itself. So, once you remove the offense, if you put the broadest diversity of probiotics into that system, it will find a way to balance itself, because each one of us individually different environment, but give it good and it will. I was actually spoke in one webinar, Philip, of actually composting all the things that human beings eat and making a capsule out of that compost. It will have all the probiotics, it'll have the humic acid, it'll have the fulvic acid, it'll have all the things you want, and digested nutrition, and you're providing your gut with what nature has. So now that we stopped eating mud, we have to put in a capsule and sell it to people to get them well again. I think we just need to go back to the old ways. They knew what they were doing when they played in the mud.
Yes, yes. Excellent. So, yes, as usual, this has been brilliant, Shankara. And just before we close out, we're going to have more of these clinical sessions over time. Just as I said, his mind and the things he comes up with are so innovative. So, we really appreciate Shankara's thinking. And just a quick reminder, a webinar coming up next week. Join us with regards to that. And please, if you're interested, make sure you join us on the newsletter. It is free, and you also get an ebook. So, Shankara, our final goodbye in 20 seconds.
I think people just need to go back to the old ways, Philip. We've been eating too much of carbohydrates. We've been eating too much of processed fats. We've been sold those things as good for us. I've made my family go back to eating things that are homegrown. You know where the source is. I've stopped all the oils in my family. We either cook with butter or lard, and my great grandparents did that, and they had none of these issues. I make sure that I'm in touch with nature, grounding, walk around barefoot, make sure I'm in contact with everything. And when I'm in contact with nature, I stop washing my hands like I do after every patient. I want to get infected, roll in the mud a little, as a kid would do. And I think that's what we need to go back to. Just getting in touch with nature and having nature restore our bio. It'll do that easily. Forget the
Excellent.
sunlight and the ventilation and all that.
All right, so just hang with me. Okay, folks, good evening, and we'll talk again soon.